Yes, sir. Sure.
We'll start, sir. Good evening, friends. On behalf of IFNR, on the occasion of World Alzheimer's Day, I would like to invite all of you. It is a very important panel discussion. We have a multidisciplinary team. This started panel, actually moderated by Ms. Vidya Shenoy, who is the President of Mumbai chapter of ARCI. I have with me Professor Surya, President of IAN and President of IFNR, as the co-chair. Dr. Surya, please.
Thank you, Abhishek. Today being in World Alzheimer's Day, and you all are aware that as the number of cases with Alzheimer's are growing, as the age and longevity has been increasing, even in our country, the number of cases of Alzheimer's disease has been increasing. It's a global challenge. The more number of cases are being recorded all over the world, and this is a very, very important problem. And to discuss on this today, we have a esteemed panel, and they will tell us about how to diagnose early Alzheimer's disease, how do we can, prevent the progression, what are the various things which can help us in picking up early diagnosis, and how to deal with these people with their memory disturbance, behavior abnormalities. And we got extremely important and highly educative panel here who are going to teach you about, give you the direction, who are going to tell you about what Alzheimer's disease is. So with that note, Vidya Shenoy, who is the ARDSI Mumbai secretary, I invite her to take over and introduce our esteemed panelists and then take it forward as a panelist. Vidya Shenoy.
There you are mute. Please unmute yourself.
Thank you, Dr. Srivastav, to welcome all of us, as also Dr. Surya for introducing me. I think it's a very special day because Alzheimer's is celebrated as the World Alzheimer's Day on the 21st. And I think ARTSI is very, very lucky to have collaboration and partnership with such a wonderful session with great expertise, being able to share with the community of how we can better the quality of life and also the well-being of not only the person living with dementia, but also the family and the caregiver. And I think, last year we had this journey through the diagnosis of dementia as the World Report of Alzheimer's Disease International. And they have made it a companion report this year with the title of Life After Diagnosis and Navigating Treatment, Care and Support, that was released this evening. And I think the topic that was selected, no dementia, no Alzheimer's, and we are talking about its management that includes diagnosis on a macro holistic level, I think is going to be not only teaching the audience, but all of us when we share whatever we know. And I won't waste time because I think there's a lot to learn from this particular session. I'm very privileged to have a panel that has been kind enough and consented to be there in spite of a busy schedule on this particular day, because their specialty is very, very wanted in the field of dementia. I'd like to introduce Dr. Santosh Bangar. He's a consultant old age psychiatrist, dementia specialist, and a neuropsychiatrist associated with Global Hospital in Mumbai. And he has 2 decades of experience in his fold. Then we have Dr. Jwala Narayanan, who is a consultant neuropsychologist, who's attached to Manipal Hospital, Vikram Hospital, and Anaswamy General Hospital in Bangalore. And we have Sonal Chitnis, who's a consultant in disorders, swallowing disorders, dementia, stroke, and epilepsy. I think these are extremely important topics that would be able to cover what we are going to discuss today. So beginning with Dr. Bangar. Dr. Bangar, would you like to explain to us and the audience what is Alzheimer's and of Alzheimer's?
Right. Good evening, everybody. Thanks for the invitation and the introduction, Vidya. Yes, World Alzheimer's Day celebrated on 21st of September every year, and the theme changes. So this year we have the no dementia and no Alzheimer's with a KNOW and not NOW. So hopefully that day will also come. But when we are faced with this question almost on daily basis, doctor, what is dementia and what is Alzheimer's? So let's get to the very basics of this. So I will make it very, very simple so that our audience can understand. So basically, dementia is a syndrome, and by that I mean it's a cluster of signs and symptoms of people who have memory loss, which is the prominent and the most commonest symptom, memory loss of recent events or short-term memory. Then there is problem with other brain functions like language ability, so understanding communication, speaking fluently, or have struggling to find the right words during the conversation or losing thread of conversation. Then organizing and planning skills. So that includes certain types of dementias as well. So generally there is a decline in all the brain functions, and typically it's a very slow onset and a progressive course. So that means once we start at a certain age, commonly after the 5th, 6th decade of life, and slowly these things get worse with time. Now, there are various diseases which which can cause dementia, and the commonest is Alzheimer's disease. So when a person gets dementia because of Alzheimer's disease, it is called Alzheimer's dementia. So altogether, there are maybe 80 to 100 different types of diseases which can cause dementia. So people who have had stroke or problems with blood supply to the brain, so it is called as vascular dementia. Then there are dementia in people who suffer from Parkinson's, called Parkinson's disease dementia. And certain other less common is Lewy body disease, which can also call dementia. It's called Lewy body dementia. Frontotemporal dementia is common in younger people, and there are various subtypes of that. So that is thankfully a lesser common type of dementia. So when that happens, it is called frontotemporal dementia. So these are the common ones that we see in the clinical practice, but the majority, which is 60 to 70%, is because of Alzheimer's.
There you are mute. Please unmute yourself.
What are the preventive measures for this? Since you've been kind enough to explain the difference between Alzheimer's and dementia. So what would you suggest are the preventive measures?
Yeah, so that's a very, very important point. And I think for our audience, this should be the most important take-home message that, because there's no cure for this particular type of illness, we have to, emphasize the preventive measures. And it should start very early on, say in the third, fourth decade of life, and not in the 50s and 60s. So when we say healthy lifestyle, that includes a vast number of things. So somebody who's got blood pressure, diabetes, so we emphasize that the control should be very rigorously done, because these are the risk factors for various types of dementia. So when we talk about prevention, we are essentially talking about how do we lessen the risk of getting this illness. Now, certain types are familial or hereditary, but that also we can argue the nature versus the nurture. So what we would say that not everybody who has a family history of dementia is going to get it. So do not worry too much about that. Coming back to what are the lifestyle measures, so eating a healthy diet is very important. Exercising is very important. For the diet, low salt and low sugar, a healthy balanced diet, whether it is vegetarian or non-vegetarian. There are certain types of diets which are mentioned. So uh, diet is also one, which means that there is more protein, less of fat, less salt in the diet. Controlling the risk factors for diabetes, so less sugar or no sugar at all. Exercise, as I said, it's very important, which includes both mental and physical exercise, because we emphasize the need for, say, daily walking or aerobic exercise or whatever, but mental stimulation, so by that I mean cognitive stimulation, so crosswords, Sudoku, keeping in touch with people, social contact, which was so very lacking because of the COVID. So social contact or socialization is one form of treatment actually for this type of disease. Stress-free life, believe it or not, but we can't, I think, live without stress. But to manage stress is important with various coping skills. So that can also lead to changes in the brain, in the hippocampus, which is one of the brain regions which is affected in dementia, Alzheimer's typically. So leading a stressful life can be a risk factor. Now, there is more emphasis on sleep. So sleep apnea or obstructive sleep apnea, people who snore loudly, that is also an independent risk factor for various type of Alzheimer's and certain illnesses like blood pressure and diabetes. So those are going to be indirect risk factors. Smoking and alcohol is also considered to be risk factors. So certain people get alcohol-related brain damage. So excessive alcohol consumption. People who smoke heavily are also at risk of developing stroke. So it's all interrelated, all these risk factors. So that is how we would say that, prevention is better than cure, and prevention must start at a very young age, not once somebody retires.
Thank you, Dr. Mangara. That means it all is in our hands to live a quality of good lifestyle if we want the thief not to enter our lives and rob us of our personality and good living. Thank you so much. Jwala, I'll come to you. What is your advice when the patients are first diagnosed with dementia? Because, we have realized that when they're first diagnosed, they're so shocked and they do not want to accept it. So emotionally, it's very stressful for the family members, not the person who's been diagnosed. And there's a lot of resentment and like, why should it happen to me or my family member? So all these things, sort of accumulate into their lives eventually. So what is your advice to the patients first?
Thank you, Vidya. Firstly, thank you for having me in today's panel discussion. I think one of the most important things that I think we play a role in and we do is psychoeducation. So we do a lot of cognitive testing before we give a diagnosis or we get a diagnosis. But I think more important than that is the psychoeducation. So we spend a lot of time with the families of the patients, firstly trying to explain what is going on. And as we know that we have so many different types of dementias, like Dr. Santosh has just highlighted. So, just giving that perspective to the patient, because I think there's a lot of misunderstanding of what dementia is, and, that everyone has to have a memory problem, or so just explaining to them what kind of dementia that patient has. And what the prognosis might look like, what it might look like going forward. And like I always tell people, I think in medicine, we're always trying to fight a disorder or fight an infection. Whereas in dementia, I always say we need to start by accepting it. And the moment we accept it, it's just a little bit easier to manage. So getting that across to families, I think is really important, and saying, and I think it's not, it is a shock when we tell them, but I think families do have a sense, because it's not something that happens overnight unless it's one of those rapidly progressing dementias. So they do have a sense that something is going on. And I think the awareness is spread so much now, compared to my own practice when I started more than a decade ago. We see patients coming in much earlier. So I think families do have a sense of that something is going on. They are progressing, they are getting worse. So just using that information and reflecting on it, and saying that, look at how things have been in the last few years or the last few months. And this looks like it might be something that might continue to progress, but it doesn't mean everything has to be dark and scary. And each patient is different, and no two people progress the same way. So I think that's really important for families to know. And what I always like to focus on is keeping them active and getting them to do what they can do. So I think focusing on what they can do is very, very important. So there's a lot that they can't do. And I think, again, as families, when they're coming to the doctor, when they're coming to us, they're always telling you problems. But what I think I try and do in the clinic is, okay, now let's look at what they can do, and let's focus on that, and let's improve those skills or try and work on those skills. Because like I always tell families, the brain works like any other part of the body. So if I tie up your one arm for 6 months, what's going to happen to it, right? So the same thing is happening in the brain. So if we stop using it, we lose it. So we need to keep that brain active, and we need to keep it engaged. And by concentrating on the things that they can do, we are giving the brain the exercise it needs. So just trying to sort of psychoeducate the families on that, focusing on what they can do. The other important information that I share with families is to observe, because a lot of the times patients might not be able to express how they're feeling or what they want, or even if it might be pain or it might be some discomfort, and that can sometimes cause a behavior problem. So sometimes it's very important to just observe the patient before running to the doctor and saying that, this is going wrong, or they're being really difficult right now. So trying to just observe and see if there might be something as simple as, in the evenings, it's the house is just not lit enough, and that's why there is more anxiety, and that causes behavior problems. Or there is a particular person who comes into the house and the patient is not comfortable with them, and that causes problems. So just tweaking a little bit of the environment sometimes can help alleviate some of the behavioral problems that we do come across in dementia. And also not to forget that, patients are changing. And I think what we tend to do is compare them to who they were before. And I think when we do that, we're being very unfair to ourselves and the patient, because they are changing. They're not going to be the same person. So I think in terms of families, we're just disappointing ourselves more when we keep comparing them to who they were. So trying to accept them for who they are right now and, help them through this journey now is, I think that should be the focus. So helping them understand that the patient might not be able to take initiative. So when you say, doctor ne bola hai ki exercise karna hai, the patient's not able to process all that information. Maybe they understand, yes, exercise is good for them, but they're not able to plan and say, okay, when do I go for my exercise? So those kind of things, we need to sort of help them and, give them direction and plan it into their routine, doing things. So I think these are the main things that, we sort of focus on in terms of immediate advice. And also checking all their other, like Dr. Bangar said, all their other vascular risk factors, and making sure things like hearing and vision. It always amazes me how so many of our patients have hearing issues, and for so many years, and we know that can be one of the biggest risk factors. So just making sure that we help them with the hearing aid or getting proper glasses. Because those things then, if you think of it again from the brain point of view, if you're not hearing well or if you're not seeing properly, then that part of the brain is not getting enough stimulation. So just making sure other things are also sort of looked at equally.
Thank you, Jwala. I think you have a point there where, the testing of eyes and ears is very important, because there are a lot of families who come up saying that, they're not responding to us, whatever we talk, and they don't do what we ask them to do. And the first thing we say is, when did you have the last, hearing test, or have you checked their eyes? And they say, oh, maybe about 5 years ago. And I said, I tell them that it's very important that, these things are taken for granted. And I think we have to see that they can hear to respond, instead of saying that they're not, responding at all. So coming to the hearing and the speech, I come to Sonal. Sonal, thank you for coming. I wanted to ask you, as a speech language pathologist, what is your role in dementia rehabilitation?
Thank you so much, ma'am. I congratulate IFNR team and AIDSI for this wonderful collaboration of patient education, public awareness on dementia. It does educate our professionals who are not well educated on dementia, that there is so much rise in person with dementia nowadays. And dementia is a multifunctionality, multifaceted disorder of cognition. There are so many challenges and so many causes. So we need to have a teamwork, like a neurorehabilitation in dementia, for the assessment from the milder stage or a questionable stage to the advancing progressive stage. We need to have a team. And I, being a speech language pathologist specializing in dementia care, we play a very important role. Like when person with dementia who could be reported by the family member or who himself or herself has walked it, that I'm not remembering so well, or he might say or she might say that, oh, I find difficult to get correct words. Of late, I don't remember someone's face, or the person might have difficulty in performing the way he or she was earlier. So there are so many changes in behavior, in their talking, reading, writing, understanding, performing, organizing, being what they were earlier. So from the beginning, we play important role in assessment, that we have series of cognitive communicative tests which can identify even a subtle changes, that the person has trouble in getting words. They may not have a very frank aphasia, which says that you can have a very non-fluent aphasia. They don't get complete word at all in early stages, or they may not be having a frank fluent aphasia, like a jargon, which we see in some stroke patients who have got an extensive posterior lesion. But aphasia in dementia could be from the milder stage to advancing stage, very different. And helping them to remember, pay attention, work on a verbal executive function, non-verbal executive function, to communicate, to have a meaningful life, and to even delay certain aspects of their cognitive impairment could be really helpful role of mine and the SLP. Now, next important role is, many patients with dementia might have difficulty in swallowing, eating. So they sometimes gobble food, they hurry, sometimes put the food in the mouth and they might choke. Sometimes they don't understand that they have to even eat, or they steal the food and they go on eating the sweet uh, food more than the other blanch food. And we know that elderlies are given most of the time very blanch and a plain food. So if there is the difficulty in swallowing, is it safe that he or she is swallowing, or is she requiring an adequate instrumental and behavioral assessment of swallowing and intervention? So being a speech pathologist, we play important role in swallowing care in dementia, to decide that the person should be fed in what consistency, what posture, how the cues can be given so that he takes adequate morsels, chews properly, formulates the bolus, and does not hurry. Another important cognitive, communicative, and swallowing, what I tried telling my role. Yes, we do have a very important role of case manager. Like when the patient, when there is a progressive disorders, they do not improve, but after the therapy, they will have some improvement and they could be plateau and they progress over the time. So your therapy, your care, rehabilitation needs as per the family and the patient changes. So you have to manage the case as a whole with his or her needs, societal needs, and help the caregivers connect with him so that they don't lose essence of that person who he or she was earlier, mother, father, or someone's brother or someone's spouse. That how you can still connect with them, that they don't remember, they don't understand, but how you can slow down on talking, connecting, use some environmental cues, some picture communication or word communication boards or signs or some apps, so that you can connect and improve the communication. Coming to the hearing part, I really congratulate you, ma'am. Majority of patients in elderlies, if their hearing loss is undetected and they have not been provided adequate hearing amplification hearing aid by audiologist, then there could be heightened risk of developing dementia, because deprivation of hearing and your auditory stimulation could be one reason of risking towards the higher risk of developing dementia. So they need to be hearing well, understanding well, listening well. So visual aids, hearing aids, tactile aids could be really helpful in even not just in the intervention, but even towards the early stage where many patients who have diabetes, hypertension, high risk of cardiovascular factors to develop vascular dementia or Alzheimer's. So it is like a non-deleterious process. We all are aging and we don't know who is possessing what gene that will have a what precipitating. But it's important that we work on even prevention, advocacy, general public awareness. So we play a very versatile role with psychologist, occupational therapist, physiotherapist, yes, social worker, importantly, neurologist, general physician, geriatrician, psychiatrist. Thank you for this question. Thank you, ma'am.
Thank you, Sonal. I think point well taken. that any rehabilitation requires a multi-specialist team with multimodal activity, where you have to customize the therapy according to the need, not only of the person living with the comorbidity or dementia, but you have to also include the family member, because they are eventually going to stay with the person. So the job is half done by the family, that encourages support to the therapist and the specialist to get better. Also, second thing you said was hearing was important. I think it's very, very important, because if there is a hearing loss and there's no reformatory act taken with a hearing aid or application that would help them hearing, I think they could go into depression, which is so easy for them to slip into, and it will actually aggravate the process of going further into the next stage of dementia. So thank you for that.
Add a small point. Yes, when they don't understand, they don't process, and they don't recollect, because the short-term memories don't help in auditory memories going together to process what was told and what I should be responding. When they don't have auditory amplification or auditory adequate feedback, then there is a heightened breakdown in communication. And many of us in our fast life, we speak fast. We switch from mother tongue Marathi to Hindi or English. And the person who earlier might be a CEO, accountant, versatile teacher, very dynamic, quick learner, when they have a dementia sipping in, they find difficult to remember and understand. So when they can't process, and in the presence of hearing loss, it makes matter worse. And then they become suspicious, they become depressed, they avoid talking to people. And this avoidance is not good for their health, overall cognitive health, social health. And the same person may stop going to functional functions or society or mandir or any needs, what the spiritual needs of the person are. So I feel it's very important to take care of the sensory cognition also, and the serial testing of those patients. And then, are they adequate? Are they helping? If not, how, as a caregiver, we have to tell them to modify their talking, communicating. So that's very important part, ma'am.
Thank you. Since you spoke of switching into languages, I think could come in, because she specializes in bilingual. How her screen is frozen. Okay.
Sorry. Yeah, I missed that question. You said something about switching language?
Yeah. Since you specialize in bilingualism, and Sonal was mentioning that how, as Indians, we tend to switch into multi-languages in one conversation, and it's a matter of convenience or whatever, or a habit. So since you specialize in languages, bilingualism, what has your experience been as a practitioner of persons living with dementia getting muddled up or fuzzed up when somebody switches languages while communicating with them?
Yeah, so we've been doing some interesting work on looking at language loss. So because we have so many bilinguals and multilinguals, we've been looking at language loss, second language loss, especially in different types of patients with dementia. And one of a very striking finding that we found was patients with semantic dementia. It's a variant of a frontotemporal dementia, FTD. They tend to lose their second language or their third language much earlier. But I think language loss is something that we do see across many dementias. So even a patient with Alzheimer's, their second language or a language that they're not using too often, they tend to sort of lose that language more because, again, it's out of practice. So they're not using it as much as they used to use it before. And so that language ability starts to degrade over time. But like, some of the PPAs that we call primary progressive aphasias, and Sonal would know very well about that, we tend to see that there are different language loss depending on which is their strongest language. And sometimes that can be a clue that there's something going on as well. So it can be a clue for early diagnosis. And in patients like that, what we usually tend to say is we want to keep their language skills as much as possible. And it's a good exercise if they can practice using the other language as well. But if not, then just being able to use the language as much as possible. So in terms of speaking to people, listening to podcasts, watching TV, just keeping that language ability going for as long as possible is really important. And as Sonal also said, if we do see that over time, that language ability is degrading, sort of using other ways to allow the patient to communicate is very important, whether it's through pictures or videos, because the moment they stop communicating, that's a whole area being cut off in their life. And then the dementia sort of progresses faster.
With the mom, I want to add the point. Many this Alzheimer's patient in an early phase do not have a very frank language impairment detected on the very subtle and brief screens which we have for many patients. If they have a good cognitive reserve. Now, what is cognitive reserve? Many people who do not understand the reserve, like we know about the vehicle on reserve, the same thing, we have a neural networks in the brain. So more languages we have learned, read, gestured, or written, we have a more great networks formulated in our brain. So bilingualism had been actually postulated to have a protective effect. And how is that on the dementia part? Because not this language, other language networks, if they are still working and not degenerated, they might get lit. So the person is still trying to get some words, communicate. So language one, native language, or second official language, or third. So more languages we had been earlier using, preferred to communicate. So that is very important. Now, education also matters. Many people in our South India, North India have functional literacy or very poor literacy. But if they are social and they like to talk to people, listen music in different languages, the bi-music people, they might have a good reserve and they may respond to your therapy talking with some favorite songs, favorite singers. So, that is very important part in dementia, which does not get tested or even intervened or used. So it could be helpful if we see the person could be mild dementia or moderate dementia also, but how well preserved are his abilities to understand or to sing or to hum, to recognize some people. So now there's a right brain and left brain in our brains. So left brain is more for the language processing and production and praxis. So the people with difficulty in speaking, understanding, have more of left side atrophy. But if there is more of right side atrophy, there would be more of insight, apathy, the facial memories. But if the left is more preserved, they may not have very severe aphasia, dysarthrias, and apraxias of language and speech aspects. So that could be helpful in understanding what therapy might work, what intervention may help, and what family members to do when you have to help this patient to still have some part of communication, his praxis or her praxis to be continued. So that could be a very important point to note and while in our assessment tools. Thank you.
Thanks, Sonal. It's so interesting. But Dr. Santosh, I'll request you to get in because Sonal mentioned behavioral disorders. So we'd like to know more on BPSD from you.
Yeah, so it's a huge part of behavioral and psychological symptoms of dementia, what we call as BPSD. And 80 to 90% of person with dementia would have it during their, stage or phase of illness. So it's an inevitable part of the disease process. And it's a broad umbrella term. So it includes the sleep problems, behavioral problems. By that I mean aggression, agitation, apathy, loss of motivation, whether it is just anxiety, depression, or psychotic symptoms, which are very common in certain types of dementia, or what we call as paranoid thought process. Then there is something called as misidentification syndromes or delusions of misidentification. So those are also common. And other points which were mentioned earlier, that predilection for sweet, so that can lead to dental caries and pain and so on and so forth. So it's a huge umbrella term, what we call as BPSD, and that is a particular challenge in managing those, because it can affect the quality of life, it can increase the carer stress or carer burden, and families can have a lot of problems dealing with them, because it affects their own well-being. Commonly they're either the son-in-law, daughter-in-law, or daughter or son, or even the spouse for that matter. So it takes a huge toll on their own personal and professional life, both alike. So managing that is a challenge, not only for the family but for the physicians as well. So that will need a holistic and a team approach. Psychological assessment, what we call as functional assessment of behavior. So as Jwala mentioned earlier, that we need to observe them and understand what they are trying to communicate, because if they are in pain, they are not going to say, this is all depending on the stage of the illness, that they are in pain. So we liken that as a young toddler who's screaming and shouting. So we have to identify that why the toddler is screaming or throwing a tantrum. So if we take that analogy into a person with dementia, they're actually trying to communicate maybe pain or constipation, that's why they are aggressive or agitated, or that may lead to psychotic features as well. So that is what we call as functional assessment of behavior. Then later on, we need to, of course, diagnose whether there is any underlying physical cause that is manifesting as a BPSD. So, routine simple blood test, urine test, or a good and a careful history from the family or observation of the behavior can be very crucial in managing. So apart from medication, of course, there are other treatment, or what we call as non-pharmacological measures. So I always emphasize that if that fails, then we resort to some of the medication that I prescribe. But we have a very high threshold, because the risks of these medication and the side effects are very high in senior citizens, and they may have other comorbid illnesses. So drug interaction is also very rife. So those are the things we have to bear in mind. So non-pharmacological measures, talking about that, and there's a good evidence for all these that I'm going to mention, is music therapy. Whether it is either listening to music or even humming or playing an instrument, those sort of things are very important. Reminiscence therapy is another one. So as the word says, reminiscence. So, sitting with a live album or what they have been doing. So because the long-term memory is fairly intact until later on in the illness. So that can be very helpful. So what we ask is, for the family member to sit and spend time with either with old photographs or, some things like, where did you work, mommy, or, which school did I go to, and things like that. So just to jog their memory, and that will get them talking, because the long-term memory is usually crystal clear until later in the illness. Then we talk about animal-assisted therapy or pet therapy. Some people have pet, or some people have dislike for a pet. So no point in trying that, because you will scare that person and make them more anxious and nervous. So the animal-assisted therapy is also, there's good evidence. Then obviously there are what we call as cognitive stimulation therapy. Those are very useful. So that will be the usual things we recommend are Sudoku, crosswords, and spellathon, and those kind of exercises. Art therapy, drawing, or even coloring, or crochet. So those things are very important. Then dance therapy, when we talked about singing, so either a person may like to shake few steps here and there, and that's very important. There's good evidence for that. Simple enough, like tactile stimulation, or just sitting and holding a person's hand even for 5-10 minutes has shown to improve and reassure them and lessen their aggression and agitation. So these are some of the very common yet very effective, and we can all do this at home. I mean, it doesn't need a very experience or expertise in this kind of field, but these are easily done at home and by the family members. And the last thing, when all this fails, obviously we talk about medication, which there are very have to be under medical guidance and supervision because of the side effect profile. So we keep that as a last resort, and there are certain groups of medication which are safer than the others, because these meds can cause problems, side effects, falling over, too much sedation, worsening their heart disease or diabetes. So we have to be very careful. And the dictum in old age psychiatry is start low, go slow, and stay low. So that is pertaining to the dose of the medication that we recommend. Thank you.
Thank you, Dr. Santosh. I agree when you said that, holding a hand or just a, hug, I think is very important. The non-verbal body language conveys much more than 1,000 words. Also, music, as a practitioner of music therapy, I think, the process of hearing and not hearing is very easy, because the last thing to go is the hearing. And music is something that has different genres. It helps you in different frames of mind. It helps in mood swings. So I think music is a very good therapy. Communication shouldn't ever stop at all, whether it's verbal or non-verbal. And you should have an eye-to-eye level of communication, because just as a child admonished, if you're standing 2 feet higher than the child, is going to react in a violent way, baby adults are going to behave likewise. So I think that is important. And then you get to pet therapy. And, at the daycare center, Universe of Memory, Smriti Vishwan in Mumbai, we have all these therapies done. And what we found is that though they were scared of dogs, small breeds, I thought bird therapy was great, because we found a very good response. We used to have the bird in the cage, and the bird would sing along and they would start whistling. So I thought the safest thing was, okay, you sit where you are, we are sitting where we are, and let's sing along. And, we had one family member with dementia who wouldn't talk at all. And we found that over 3 sessions of the bird therapy, he actually started mumbling, and then he was trying to form words. And we had a speech therapist, suggested to the family, and they started, and he started talking. So I think bird therapy is very safe, and so is doll therapy. Doll therapy also helps a lot. And as you said, dance, I think music and dance is very closely related. And just as you can hum your troubles away, I think you can shake your leg and, ventilate your mind. So I think any relaxation, even if we are people living blessedly with no comorbidity, I think music is a very good thing. Thank you, Dr. Santosh, because you're reinforcing whatever we are doing at the center as a medical professional. Now, I had to get back to Jwala because he spoke of family support. Okay. So I would like to know from you, once the person is diagnosed with dementia, what is the role of family in supporting the person with the disorder?
Yeah, I think the family, plays a very important role. And I think they need a lot of care. So I always, encourage families to actually start support groups of their own if they can, because it's very important to sort of be able to have a group of people you can talk to, you can vent to. So it's very important, and also discuss and share, because sometimes you can't always go to a doctor or a professional to sort of get advice on something that has happened at home. So when you have a group of people who are dealing with similar situations, they might be able to give you some suggestions. So I think, just trying to find your support group, or it can also be just, talking to a friend, talking to people. So it's very important to look after yourself first. So I think as families or as the primary caregiver, it's extremely important to look after yourself first, because if you don't look after yourself, you're not going to be able to look after your loved one well enough. And they do sense, patients with dementia, even with their dementia, they can sense anxiety, they can sense sadness, they can sense frustration, and that can also cause behavioral issues with them, or that can cause depression. So if you're not healthy, they won't be healthy. So you have to look after yourself first, and then you have to, of course, look after your loved one. Some of the things that help for families is try to maintain a routine. I know this is hard, but I always tell families that if you get it right, if you're able to set a routine for about a month, it will get better, and then the routine does set in. And even a patient with dementia can learn a routine. So they do well with routines, because then there are no surprises, the anxiety levels come down, they know what to expect next. So try to keep a routine, and it would really help them also engage in activities. So they know that, okay, morning after they get up, they're usually taken for a walk. When they come back, they have to help with a little bit of cutting or peeling of some vegetables, or maybe folding. And then after that, they have their breakfast. So if there is a routine, even they know what to expect next, and you'd be able to get them to engage in activities better. The other thing I think families, we always sort of remind them, is they are not going to be able to take initiative on their own. So you have to guide them. You need to help them. You can't expect them to be able to take that independent decision. But at the same time, try and keep them, as active as possible with whatever level they're at. And that's really important. A lot of the times you can save yourself, further complications by just making sure, again, you're organized and there is a check on their hygiene levels, because that can cause secondary infections or other problems. So just making sure there are systems in place to make sure that they have, their routine dental checks, or if they're constipated, or if they have any infections. So just making sure that their general health is looked after. And that would save you a lot of trouble in terms of any other complications that might come. And also take breaks, take rest. Just because you're looking after someone, it doesn't mean that you have to be stressed all the time, or you can't be happy, or you can't smile. That's not, it's not something that you have to be sad or stick to that. You can still be happy if you're caring for someone with dementia, and you need to be if you want them to be a little happy. So that's what we usually suggest to families.
Thank you, Jwala. You said it very correctly that we have to think of a lot of factors, when you're looking after a person with dementia. And it's like the airplane, they say cover your, you put the mask and then you help the child. So it's something like that. We have learned one last question. We can go on and on and on, but I think at this point, I'd like to ask our young Sonal, who's so enterprising and bubbling with energy. What do you think, very briefly put, how the new technology would help? Because I'd like the chairs to come and put in their experience and, express their feelings also and thoughts.
Thanks for this question, ma'am. As I really like phones and gadgets and like to connect to people and do a lot of imaging and neural correlates, I feel technology is very important. And why not using the same technology to improve and intervene the cognition, communication, safe swallowing? So there are low-tech and there are high-tech technological aspects which can be utilized in our Indian patients. So, there are stroke patients, stroke dementias, there are Alzheimer's, Parkinson's disease dementia, there are different progressive dementias, rapidly progressive dementias. So there are different dementias requiring different needs. So having a dementia friendly society, we require definitely some gadgets, so that if the patient is wandering, we need to make sure that they are safe. If someone is not there with the patient, so having a GPS tracking or some simple smartphone, smart watches can be utilized as a low-tech technology, or a high-tech technology, we can have some memory aids, alarming devices at home. We can have some simple communication aids also, like you touch the icon, it will talk for you. You have some simple phrase making apps available for communication. And there are so many nice apps available nowadays for developing and enhancing or even aiding somewhere's memories or somewhere everyday life skills, or while crossing the road or taking the person to the mall or some nearby society places. So it's important that we utilize the app. So if you can just Google the Cambridge Dementia Friendly Society, Dementia Cafe, there are a lot of good material available, which is obviously UK culture based thing. But in India also, we can actually make cross-culturally valid and somewhere friendly, simple text, gadgets, apps available, which can help the person with dementia and the family to connect.
I'll take this opportunity and thank Dr. Santosh, Dr. Jwala, Sonal, Dr. Abhishek. Wonderful session that has been organized.
Thank you so much, ma'am.
Exchange of views, opening vistas of new potential for carers, families to help their loved one to the utmost best quality of life and well-being that they can do. Before I hand it over to Dr. Abhishek, I would like to take this opportunity and thank the Bruhan Mumbai Municipal Corporation, BMC, for having collaborated and understood the seriousness of the problem of dementia. And we're looking forward to working together in many other areas. And, we started with the celebration of the illumination of the headquarters BMC at VT with a purple color and gratitude, deep gratitude. And we made a start, and we don't we don't let anybody off easily when there's potential to work together hand in hand to create a dementia-friendly city. And secondly, to see that all of us take the onus of supporting one another to see that all of us are living a good quality of life at not the expense of anyone else. Thank you. Dr. Abhishek?
Thank you, Vidyaji. I think we all have learned some very simple things that dementia can be primary or secondary, and stroke and PD and TB can also cause dementia. Very important thing. Second, dementia is not just a memory problem. It involves multiple aspects of cognition with emotions, behavior, self-care, swallow, communication, all can be involved. And hence, a multidisciplinary team can deliver better outcomes than a single person-driven programs. And as there are secondary reasons for dementia, prevention is better than cure. Dr. Bangar spoke about it. Healthy lifestyle is very, very important. Also, people who are caring for people with dementia. So caregiver stress, caregiver burden, very important concept. So let's talk about cognitive reserve. Let's talk about bilingualism. So people who are bilingual have more cognitive reserve. It's a good way to protect your brain. And exercise is not just physical. It's physical plus cognitive exercise. Both works very well. I think I learned a lot, and I hope all of us must have learned the simple tips. With this, I would thank Vidyaji for holding the session, Dr. Bangar, Jwala, and Sonal for very nice contribution. Thank you very much. With this, we close this session. Thank you very much.
Thank you. Thank you, everybody.
Thank you, sir. Thanks. Bye-bye.
Thank you and good night.
Thank you, sir.